So, ma'am, we are live now. I will start.
Yes.
Good evening, delegates, faculties member, and participants. Thank you for joining Shield Connect. Today, we are with Kavita Bapat ma'am's Learn Simply at Tea Time. And this is the joint webinar of Beed, Jalna, and Osmanabad Obstetric and Gynecology Society. So let me introduce the convener for this program, Dr. Richa Patel, ma'am, Dr. Richa Narkade, ma'am. She is the associate professor at LNGT Medical College and SK Hospital, Indore, and associate consultant at Bapat Hospital, Indore. So I will hand over this session to Dr. Richa Patel. Thank you.
Thank you, Nishant, and thank you, Shield. Good evening, everyone. I welcome you all to our joint webinar on Beed Society, Jalna Society, and Osmanabad Society. Thank you for taking the time to join us today, and I would like to take this opportunity to introduce our eminent chairpersons, Dr. Poonam Yedle ma'am from Beed, Dr. Swami Lalita ma'am from Osmanabad, and Dr. Vijay sir, Shinde sir, from Secretary Jalna Society. Dr. Purnima Yenli ma'am, she's a director of Sri Kripalu Hospital, Beed, practicing obstetric and gynecology since the past 20 years. And she's having a special interest in high risk. Member of district PCPNDT and MTP committee, pioneer of cosmetic gynecology in Beed district. Dr. Swami Lalita ma'am, she is consultant gynac of Swami Hospital, Osmanabad, ex-medical officer at Women Hospital, Osmanabad, and 18 years of experience. And Dr. Vijay Shinde sir, he is a consultant infertility specialist at AAI Hospital Private Limited, 18 years of experience. He is a secretary at present of Jalna's Obstetric and Gynecology Society, and DFP gold medal in 2003. I would like to thank you all for joining us, and I would like to hand over this session to Dr. Purnima ma'am and to take it further. To you, Dr. Purnima ma'am.
Thank you, Richa. It's a great honor to introduce Kavita Bapat madam today. The topic of today's lecture of madam is unexplained, unexpected stillbirth, which I believe is every obstetrician's nightmare. I think words are not sufficient to introduce Bapat madam. As she said, her passion is a profession. The director of Bapat Hospital at
Purnima, nothing to worry, we won't waste time. Whenever, I think you are stuck somewhere. I think the problem of internet is somewhere.
Internet is there, ma'am. Yes.
Yeah, no problem. Yeah.
She's back, ma'am. Just few seconds.
And I also request you all to, as madam is standing for the post of president of Oxford, to vote for her.
Thank you so much. Thank you so much. I am blessed, Purnima. I think most important point is, sorry for my voice and everything, because I travel so much and jago jagi kuta kuta firat aste and konsa pani piti mi. I myself know, and the flights for the infection is also picking. So sorry for the voice and sorry for everything. Allow me to share the screen. Yeah. Today's topic is basically very important topic. As Purnima said, that it's not a subject of one person. It's a family. It's a social taboo, I am telling you. Kadipan, whenever we see if there is a stillbirth, the worst part of the thing, number one, how to declare it. Number two, how to cope up with the family, relations and everyone.
Madam meeting madhe.
And third point is just to see the family faces, and it's really the troublesome to tell mother, to tell family. And the fourth important point is so many medical legal points have come when there is an unexpected stillbirth. So make it a point. It's not a one day's problem. And the worst part of the story, so much research for the cost and the reasons for stillbirths are yet to come. There are no green top guidelines, no RCOG too much guidelines, how to deal with a previous SB and now what to do. So, but just to make it simple, as our purpose is learn simply. And thank you so much all of you for joining today. I'm so happy to see Dr. Adinath, Dr. Dipti, Dr. Lalita, Dr. Vijay, Dr. Vijay. So thank you so much, Purnima and everyone, for being with me today. And thanks to Anil also for arranging this for us. So the definition is not all fetal deaths are stillbirth. That's a very important point. And another important point is World Health Organization, fetal death late in pregnancy allows each country to define gestational age at which fetal death is considered stillbirth. So from country to country, state to state, the fetal the definition of stillbirth also changes. Some considered it 16 to 28 weeks. National Center for the Health Statistics, most status, the use of 20 weeks or the fetal weight more than 350 grams or more than 500 grams. Sometimes the late stillbirth is 28 weeks. And this is a Tennessee code annotated. They say the fetal death more than 500 grams or absence of weight, if we are not considering the weight point, it should be more than 22 weeks. So you can see that the problem starts from the definition only. You are not able to define it properly. Every country, every World Health Organization is talking different, right from 16 weeks to 22 weeks, they can defining it. It's a stillbirth. Then, my sorry for today. Then the incidence. More than 3 million stillbirths each year worldwide. The rate is 2005, it's 6.21 thousand total birth in USA. Then rate of early stillbirth has remained stable. Rate of late fetal loss is decreased by 29%. Because this is the condition in which if we are able to give the good prenatal care, we are able to reduce these chances are there. Since 1990, African American have 2 times more stillbirth rate as the Caucasians, because there are more diabetes mellitus, hypertension, and abruption. These are the 3 other conditions rather than the race they are causing the problem, and the premature rupture of the membranes. Now, why this happens? Why stillbirth happens? Unknown 25 to 60%. Now we are worried about only 40% because most of they are unknown and they happen and we are unable to find it out why. Identifiable cause can be attributed to number 1, the maternal conditions, number 2, the fetal conditions, and number 3 is the placental conditions. So the maternal conditions is number 1, prolonged pregnancy, diabetes, which is poorly controlled, systemic lupus erythematosus, LSSLE, then APAS is another thing, infection, hypertension, and preeclampsia. Eclampsia, immunoglobulopathies, AMA, RH disease, uterine rupture, maternal trauma, or death. And the worst part is inherited thrombophilia. So the fetal conditions, again, multiple gestation, IUGR, congenital anomaly, genetic abnormalities, infection, and hydrops. Placental condition, again, cord accident, abruption, prom, vasa previa, fetomaternal hemorrhage, and placental insufficiency. But the most important point, I can divide this type of lectures into 3 divisions. 1 is to the causes, for the medical profession, for the reasons, for management, for this thing. Second, this topic is very much important for the respectful maternity health care. This is another full thing. The family, how they are bereaved, how the baby should be buried, or how should the antim sanskar of that baby should be done. There's so many things. And third is the most important aspect of the stillbirth is how to save ourselves from the medical legal issues. But here we are just dealing as a professional persons and we are talking about the stillbirth regarding the causes, etiology, and all. So the most different types of the stillbirth according to the gestational age, we divide into 3 classes: 24 to 27 weeks, 28 to 37 weeks, and 37 plus weeks. 24 weeks, now chances of infection 19%, 28, 37 unexplained 26%, and 37 plus weeks unexplained 40%. 24 weeks abruptio placentae, it causes 14%. Fetal malnutrition 19%, and 37 is a fetal malnutrition 14%. Anomalies 14%, abruptio placentae 18%, and abruptio placentae in a 37 plus weeks 12%. The number 1 reason is infection. most common cause of stillbirth, 24 to 27 weeks, and it contributes stillbirth rate difficult to define. Pathogens are not clearly and casually related. They can be parvovirus, they can be cytomegalovirus, they can be toxoplasmosis, and some are associated with stillbirth absent of evidence of any infection. That's most important point. Nothing is there, and stillbirth is still there. Then one is this. Uriplasma urilycetium is another cause, and Mycoplasma hominis is one of the cause. And GBS. We don't test for the patients for the GBS in our country because we think that's profound all over there. But GBS is one of the most important streptococcus, which is important. And colonization common among the healthy women. Again, for the infection, most stillbirth occurs in a premature fetuses, 24 to less than 28 weeks, 2% stillbirths at term, and no change despite the widespread use of antibiotics. You can give a plenty of antibiotic, but no chances to change. Then viral pathogen are most common source of hematogenous infection into the placenta. Fetal death resulting from maternal infection is rare. So you try to understand it's not because of the mother infection, but the most of the time the infection is into the placenta or somewhere can lead to this thing. And the diagnostic criteria are not well defined. So how can we say that this infection was there and the baby died? And to prove it, to tell it, to explain to the patient, to the counsel to the patient, further monitoring of the patient and what we are going to the next pregnancy, it's really a dilemma. So high frequency of asymptomatic maternal colonization. Then another important is a multiple gestation. We all have seen, I think I'm finding all senior OBGYN over there, and we have seen stillbirth in our lives. I'm extremely sorry for this. It's a complication specific to the multi-gestation. This is the TTTS. That's a very important. Transfusion syndrome is there. Increased risk of common complication, AMA, fetal anomaly, and growth restriction. And then the fetal advanced maternal age, there's some lethal and congenital chromosomal anomalies, medical complication. I'm sorry, I think I should stop. Then hypertension, diabetes, and the independent risk factor is another point. Unexplained fetal demise is the only type which is statistically more common. I think risk is because of socioeconomic and the obstetric factors, smoking, diabetes, preeclampsia, and risk remains even after controlling for above theories and the perception of the fetal movement. So advanced maternal age, multiple gestation, and third is infection. These three things are very important. Hyperlipidemia is another thing. So the obesity, hyperlipidemia, apnea, hypoxia events can lead to this thing. Again, obesity and stillbirth rate. BMI less than 30, chances are 5.5. More than 30. It's 30 to 39.9, 8 per 1,000. And the BMI is of grossly obese females, more than 40, the chances are 11 per 1,000. So it's a big point. Obesity is a really bad thing. Then another than infection, multiple gestation, advanced maternal age, and then I talked about obesity, and then this point come about the chromosomal abnormality. Abnormal karyotype found in 18 to 13%, more than 20% with anatomic abnormalities or growth restriction, 4.6 with a normally formed fetuses. Most common abnormality are monosomy, trisomy 18, and trisomy 30. Karyotyping analysis underestimates the risk because once the baby is out and the risk we have found out the stillbirth, we have to get all these investigations done to prove it the reason for having the stillbirth. Again, obesity, I think this is another point, what method they should have. Amniocentesis 85%, fetal tissue sampling 28% are there. Now, what is fetal tissue? Umbilical cord, we can find it out 32.1%. Fascia lata for the abnormal chromosomal abnormality. Fascia lata 29.9%, cartilage 24.2%, fetal blood 22.2%, pericardium 0%, and other tissues 19.2%. So once the baby is out, that is stillbirth, we have to get the fetal tissue test done. And they have found around the analysis, They have done the abnormality they found in the umbilical cord 32 and other tissues 19.2. Placenta, skin, unknown. Then the cord accidents. 30% of the normal pregnancies account for 2.5% of the stillbirth at autopsy case series. And there are the attribution requires cord occlusion or hypoxia to the tissue to the autopsy. So while doing the postmortem of those babies or autopsy being done, and they have found out that the cord problem is there is most of the cases there is a cord occlusion, or they have found out the hypoxic tissue at this. And they have to exclude the other causes. Then the actual proportion remains uncertain. Whatever the causes, whatever the reasons I am telling, or whatever the problems I am talking about, the last line you can find out in the same in each slide. That the actual proportion remains uncertain. So that's the worst part of the stillbirth. I'm telling you, this is really the worst part of the stillbirth. Then the thrombophilia. Relationship with the late fetal death is more consistent than the early losses and associated with the late loss, but lack of evidence for the causal relationship. Inconsistent studies. Their studies are not so good. Thrombophilia are not uncommon, means it is common. 15 to 25% in the Caucasian population. Thrombophilia, again, they talk about some but not studies show the relationship with the adverse outcome. Most are retrospective and case controlled. There is a longitudinal studies are needed. Again, this is a problem which is uncertain, inappropriate, no controls, no evaluation, and at least one type of thrombophilia is seen in 30% of the normal controls. Now, what evaluation we have to do once we see the baby of SB? Then what's our condition? What is our role as an OBGYN? First and foremost, fetal autopsy. We should offer fetal autopsy to each and every baby who is a stillbirth. And I'm sure all over people sitting over there, 99% patients of ours, they refuse to do the postmortem of that baby. And number one. Number two, we are not trained so much to tell each and every patient to get it done also. So number one is a fetal autopsy. This is a single most useful test. It will prevent from the medical legal issues, number one. Number two, any obstetric problems in number two. And number three, it will save us from the next pregnancies also. So the fetal autopsy is must. Examination of the placenta, cord, and membranes. All three things should be examined. Karyotype evaluation is must. 18 to 13% of the stillbirths compared to a genomic hybridization. Useful when fetal cells cannot be cultured. The worst problem, another is, we get the fetal autopsy done, but we want to fetal cells to be cultured. The chances of fetal cells culture is also not possible. Then the infection. Autopsy and histological evaluation of placenta, membrane, and cord provide best evidence of the infectious etiology. So it's good. Then the value of routine culture and serology is controversial again. What is the parvovirus serology? Screening for syphilis, torch titers, questionable, and utility. Kare ya nahi kare? Do or die? It's a dilemma. It's a dilemma. Then the placental culture problematic. Another very, very important. The incidence in a live birth is unknown because why see the difference between the two? We have never done so many studies of the placental culture in the live birth babies also. So with whom to compare? To whom to make it a study and how to do it? It's a big problem. DNA test associated with the false positive. So another big problem. Now, this is the problem which we do. Now, medical complication. Once there is a SB, what complication that mother can have? Clinically overt diabetes or thyroid dysfunction is there. So we should treat it. JDM has a stillbirth rate similar to normal. Subclinical thyroid disease has not been proven as a cause of stillbirth. Screening of subclinical disease is unproven benefit. Then why we need to do antepartum surveillance? In the antepartum surveillance is for those who had a previously stillbirth baby. So little evidence based on the data testing the previous unexplained stillbirth, 32 to 34 weeks, 2 to 4 weeks before the gestational age of the previous stillbirth. So it's our duty if previously the baby is delivered at 36 weeks and it's SB. So we have to deliver that baby 32, 34 weeks. But there is no official guidelines, no GCPR, nothing is there. Then increased risk of iatrogenic prematurity. If I deliver the baby at 32, 34 weeks, I have to explain why I have delivered this baby prematurely. So the chances of iatrogenic prematurity is there. And subsequent pregnancy have a favorable outcome. Another antepartum surveillance, 300 women with a previous stillbirth, 49 unexplained, 1 recurrent stillbirth despite the reassuring testing, perinatal mortality 3.3, earliest delivery associated with a positive result in the 32 weeks. Then what protocol we should use antepartum for this patient? Protocol no not be appropriate for all previous stillbirths, non-recurring condition. This is another important thing. Stillbirth is not a recurring condition. It's a non-recurring condition. There is a maternal trauma. There can be uterine rupture, abruption, prolapse. There are perinatal infection and a fetal anomalies. So following the OB complication that can recur and cannot be predicted. So the conclusion is stillbirth is an important indicator of the quality of a care in a pregnancy and a childbirth. It's a sensitive marker in the health system strength, measuring not only progress in achieving the SDG targets for the reduction of neonatal, maternal, and under 5 mortality, but also progress on the other targets aimed reducing the poverty and increasing quality and access to the healthcare. I feel very sorry to tell you about that in Madhya Pradesh, we are the last, I think one of the few last states in the India who are having the maximum maternal mortality rate. And the first part of the story, all in or India, the stillbirth discussion about the stillbirth rate, and we are talking about the SDG targets and everything. Stillbirth ke upar kaam hi kam hua hai, what I always feel. It's a very less work being done on the stillbirth, and that's a very, very important. And extra directed efforts will be necessary in overcoming the barriers to the service community and emphasis in achieving our goal. So barriers need awareness chahiye, health education, demand creation of the community, and socioeconomic up is needed. But the most important point is women's empowerment plays an important role, reducing the stillbirth, educate our own women. Thank you so much for the patient listening. And I'm so happy to see all of you, though we are less, but still I am happy that 15 people or 20 people are there, but at least some take home message or a dialogue which we can do. And thank you so much. Nice to see you, Vijay. Vijay Karle sir is also there and Vijay Shinde is also there. So over to you, and we won't waste much time and continue. Thank you so much.
Thank you, ma'am. Now we will. I would like to hand over this session to Dr. Vijay sir. Nishant, can you share CV of Dr. Adinath, please?
Yes, ma'am.
Good evening, everybody. Thanks a lot, Bapat madam, for your so sweet, short and day-to-day problem what we people are facing. I'll introduce Dr. Adinath Rajguru sir. He is a past president of IMA Dharashu, that's Osmanabad, past president of Osmanabad OBGYN Society, past organizing secretary of MRCOG conference held at Osmanabad. He is a faculty in AMOGS, UA, FOXY, AICOG, and ISAR conferences. He has been awarded with Award of Excellence by auspicious hands of Joint Secretary Health, Government of India on the occasion of International Women's Day in Delhi. He has organized many infertility awareness camps. He has participated in live phone program Sati Sahyadri on the topic female infertility and modern treatment on Doordarshan channel. Hand over to Adinath sir.
Good one, good one. Nice.
Thank you, Vijay sir, for introduction. Good evening, Kavita.
Thank you.
Purnima, Dipti ma'am, and our society president, Dr. Swami madam. I'm very much thankful to the Shield Healthcare Care for giving me this opportunity to talk on this topic. Low AMH. What next? What is new? So we are knowing AMH is secreted from the granulosa cells of the preantral and antral follicles. Just wait, I'm sharing. Can I see the PPT?
No, sir.
No, sir.
Sir, click on the
Yeah,
PPT.
click on the PPT, Kali. Kali hai na PPT.
Yes,
so,
yes,
tela click
Yes,
kara.
yes. Click on that, sir.
Okay.
Yeah. Ella mota karuge, large karuge. Yes. Good.
Yes.
Good
Yes,
job.
sir.
Great job.
So the anti-malarial hormone and ovarian reserve, the contents of today's talk are: can we improve the AMH values? Then how the ovarian reserve management is to be done? Predictors of the poor or diminished ovarian reserve patients. Then treatment protocols for the management of DOR, that is diminished ovarian reserve. When to use the donor eggs. Then reproductive planning, pro-fertility assessment, and recommendations and referral criteria for the IVF. AMH is a ovary specific expression pattern in the granulation cells of the growing, not secreted from the primordial, small preantral and antral follicles. It is a dimeric glycoprotein belonging to the TGF beta superfamily. It has an inhibitory effect on the primordial follicle recruitment as well as on the responsiveness of the growing follicles to the FSH. So AMH is secreted from the small preantral, large preantral, and antral follicles of size around 2 to 7 millimeter. Its physiological function is it prevents the excessive follicle recruitment. It is a non-cycle dependent. That means there is no variation of the AMH values when tested on the 2nd day, 10th day, or 20th day. As compared to the FSH values are to be tested in between the 2nd to 4th day of a particular cycle. It is less cycle to cycle variation as compared to the FSH. It is not altered after the hormone therapy like OCPs or estrogen therapy. It is not altered even after the down regulation with the GnRH agonist. So the AMH values are always higher in cases of PCOS. They are diminished in the poor ovarian insufficiency. The values we can predict the timing of the menopause. We can predict the outcome of the IVF and studies have shown that AMH is the most reliable marker that how much oocyte that particular lady can create. Higher AMH values is maybe the sign that the female have higher egg and follicle count, and lower AMH may be the sign that that particular female is having a lower egg and follicle count. This is because low AMH level significantly the decreases number of the egg in the ovarian reserve. Here we can see often the levels of AMH are higher in cases of PCOS. Normal range is from more than 1 nanogram per ml. Low AMH level is considered when its value is 0.7 to 0.9 nanogram per ml, and low level is less than 0.3, very low or is less than 0.3 nanogram per ml. Then what are the causes of the low ovarian reserve? Age, we are knowing as after 30 years of age, usually the AMH values and antifollicle count goes on decreasing. Poor diet, hormonal imbalance, past medical conditions, mental health, genetic factors, and environmental factors. Here, When the AMH values are good, then the antifollicle count is also good. Here, AMH values are very less, antifollicle is also less. As age goes on increasing after 25 years of age, here we can see the AMH values goes on decreasing. Then what are the causes of the low anti-mammalian hormones? Poor diet, unhealthy intake of highly processed diet, fatty food, obesity, and vitamin deficiency. Hormone disorders, menstrual irregularities, anovulation, in some cases of hypothyroidism. Past medical history of tuberculosis, endometriosis, ovarian cyst, pelvic inflammatory disease, ovarian torsion, or in some cases of oophorectomy, chemotherapy. Then the mental health, mental stress. Can we improve the AMH level? Actually, we can't increase the AMH value, but we can improve the quality of oocyte. Healthy diet and lifestyle. Healthy diet, including the raw food, avoiding highly processed food, and high fat diet. Then yoga and abdominal exercise. It is said that it improves the blood flow to the ovaries and that support the healthy nourishment of the egg follicle. Here you can see the then supplements, vitamin D, coenzyme Q10, meta-analysis of international studies performed that examine the effect of vitamin D supplementation on serum AMH level indicates a cause-effect relationship between the vitamin D and AMH values. Interestingly, here we can see vitamin D supplementation appears to decrease the AMH levels in anovulatory women with PCOS, and the vitamin D supplementation, it appears to increase the AMH levels in ovulatory non-PCOS patients. Then coenzyme Q10, the primary cause of premature ovarian disorder remains the elusive and oxidative stress, was proposed as one of the cause of diminished ovarian reserve and diminished AMH values. Whereas studies investigated the effect of antioxidant treatment with the coenzyme Q10 on the ovarian response in young low prognosis patients with the premature ovarian reserve. Then DHEA, various cross-sectional studies have shown is a positive association between serum DHEA and AMH values. The dose of DHEA 25 milligrams thrice a day for at least 6 weeks to 3 months is to be given. DHEA supplementation for at least 3 months has been shown to be associated with the spontaneous and treatment-induced pregnancies in women with a very high FSH value and very low AMH values. Then Ashram definition of ovarian reserve. Ovarian reserve is defined as the number and quality of remaining follicles and oocytes in both the ovaries at the given age. And diminished ovarian reserve is the loss of normal reproductive potential in the ovaries due to the lower count or quality of the remaining oocyte. Then we have already seen the causes of diminished ovarian reserve. family history. Other is a condition that can cause the ovarian injury like cystectomy, torsion of ovary, or oophorectomy for any reason, chocolate cyst, lifestyle and environmental factors, genetic abnormalities, then exposure to the chemotherapy, mumps, autoimmune disorders, smoking, and galactosemia. Other causes: a prior poor ovarian responsiveness incident, or reduced ovarian reserve test parameters, chronological age versus the biological age. Loss of oocyte is a continuous process. Aging oocytes have been widely suggested to be the major cause for the infertility. Here we can see that at the birth, number of oocytes are in between the 6 to 7 million at fetal life. At birth, its value is around 1 to 2 million oocytes. At menarche, its value is around 3 lakhs, and at the menopause, the number of oocytes less than 1,000. So as age goes on decreasing, number of oocytes goes on decreasing. Ovarian response is defined as the actual oocyte yield after ovarian stimulation. It is classified based on the oocyte retrieval at ovum pickup. Poor response when we obtain less than 4 oocytes at ovum pickup, indicative of the diminished ovarian reserve and low pregnancy rate. Then excessive response when the number of oocytes more than 14 at the time of ovum pickup. Here it is accompanied by increasing number of immature oocytes and ovarian hyperstimulation syndrome. Chances of OHS are increased. Then the predators of the poor ovarian reserve or diminished ovarian reserve. As per the ACOG recommendations, why ovarian reserve testings are performed? It is to assess the quality and quantity of the remaining oocytes to predict the reproductive potential. When ovarian reserve testing is to be done, if the age of that particular woman is more than 35 years, we have not conceived even after trying for 6 months, and woman less than 35 years who have not conceived even after trying for getting pregnant for 2 years. What should be done if ovarian reserve testing results are positive? Counseling to conceive as early as possible. Then ovarian reserve testing clinical assessment: age, menstrual cycle, characteristics, basal FSH testing, E2 testing, AMH, inhibin test. Then on ultrasound, AFC test, count, ovarian volume, ovarian blood flow, and dynamic clomiphene citrate challenge test. Then exogenous FSH ovarian response test. Then gonadotropin agonist stimulation test. Combination of the biochemical tests are effective predictors of diminished ovarian reserve. AMH testing, antifollicle count, FSH testing, and inhibin B. Bologna criteria for poor ovarian response. Poor ovarian response is identified by the reduction in the follicular response to the maximum stimulation during the IVF procedure. Poor ovarian response definition as per the Bologna criteria. Advanced maternal age more than 40 years or any other risk factors for the poor ovarian response. Previous poor ovarian response when less than 3 oocytes with conventional protocol of stimulation with more than 150 international unit of FSH gonadotropin given daily. Then the presence of at least 2 of the 3 these features is present, then it is that patient comes in a poor responder. Then treatment approach for the management of diminished ovarian reserve. Here group 1, group 2, group 3 and group 4. Group 1 and group 2 they are the same, except in group 1 age of that particular woman is less than 35 years and in group 2 age of that particular woman is more than 35 years. AFC more than 5, AMH values more than 1.2. AFC count, AMH value are same in group 1 and 2. Then group 3, age of that particular woman is less than 35. In group 4, age of that particular woman is more than 35. AFC count is same, less than 5, and AMH value less than 1.2 nanogram per ml in group 3 and group 4. Then this about the management of this poor ovarian reserve patients. Protocols, stimulation protocol, then trigger for the final maturation of the oocyte. If the FC count is more than 5 and or AMH value is more than 1.2, if the age of that particular female is less than 35 years, if the age is more than 35 years, GnRH antagonist protocol is preferred. In group 1, increase the FSH dose by 75 to 150 international unit and consider recombinant LH in dose of 75 to 150 international unit from day 1. Then in group 2, increase recombinant FSH dose by 75 to 150 international unit, add 75 to 150 international unit of recombinant LH from day 1. Then trigger, one can give GnRH agonist or SCG trigger. Interfollicle count to oocyte ratio, ERT calculator for the oocyte number. Low, consider increasing the recombinant FSH dose and timing of retrieval. Consider the dual trigger here. Oocyte embryo accumulation, antagonist protocol or dual stimulation, and single blastocyst transfer. Treatment based on the AMH levels. When the AMH values are very high, then antagonist protocol is preferred. Here one can give the SCG or agonist trigger. In normal responders, long protocol or antagonist protocol is used. Reduce the response. Reduce responders. Play agonist protocol. And when the AMH values and AFC is very low, then the flare agonist protocol can be used. But we should advise that couple go for the oocyte donation, as the chances of getting oocytes are very less here. Then the stimulation protocol for diminished ovarian reserve that we have already seen. Adjuvant therapy for these patients of diminished ovarian reserve, they are androgen, growth hormone, and aspirin. Then when to use the donor egg? Poor ovarian patients, those who are having the poor ovarian reserve, genetic alteration or disease, advanced maternal age, then hereditary diseases. Simultaneously, recipient endometrium should be prepared with the estrogen, valate or hemihydrate in the dose of then the reproductive planning, pro-fertility counseling with the growing chances in the society, delayed marriage, and with more women choosing to have career, couples are postponing the parenthood. As are women being a little more receptive of egg freezing, we are also seeing more of women consciously adopting egg freezing as a welcome lifestyle choice, as a need of our. Then should fertility experts engage in the fertility assessment and counseling? Yes. Then pro-fertility assessment, AMS level and ovarian aging, that we have already discussed. The fertility, then the fertility preservation, whole ovary freezing, ovarian tissue freezing, oocyte freezing, and embryo freezing. Cryopreservation for the fertility preservation, transplantation of whole intact ovary by vascular anastomosis was done in 2002, 2006, and 2007. It requires a huge technical challenge for perfusion of the cryoprotectant. In theory, risk of cancer cell transmission is there theoretically. Options for use of the stored tissue atto transplantation. The ovarian tissues, first that tissues should be thawed. First step laparoscopy for creation of placing of that thawed, that cryopreserved ovary. After second week, second step laparoscopy for implantation of ovary. Here, and heterotopic transplantation technique, most have been to over the arm, forearm, or suprapubic region. Orthotopic implantation near the fallopian tube at the natural location. If it is implanted over the arm, forearm, or in the suprapubic region, there is no need of abdominal surgery, EG monitoring of follicle growth, then EG removal if necessary. Then ovarian cryopreservation, Resumption of endocrine function has been reported after orthotopic and heterotopic transplantation. Embryos was generated from oocyte derived from subcutaneous transplanted ovarian tissue. Lot work yet to be done for routine application of this technique. Then Singapore's first baby of ovarian tissue transplanted in 2005. Thank you, friend. Thank you, Seal, for giving me this opportunity to talk on this topic. Our best wishes to Kavita madam.
So much. Thank you so much. Thank you so much. I am blessed. It's such a big topic you have covered. Your slides are also good.
Thank you.
It's a big topic which you
Yes.
covered. I think
It is very big topic.
Especially Dipti will
It is very difficult to cover in 15 or 20 minutes.
AMH is an otherwise big topic.
Yes.
Correct. Okay. Thank you so much. Vijay, continue for the next speaker.
Thank you,
Richa?
Dr. Adnath Rajguru, sir. This was a very informative video. Now, I would like to hand over the session to Dr. Swami Lalita, ma'am. Ma'am, the screen is all yours. Thank you.
Thank you, madam. Good evening, everybody. And thank you, Dr. Rajguru, sir, for such an informative and nicely elaborated talk. I am very happy as I have got opportunity to introduce Dr. Dipti Vaidya madam. Dr. Dipti Vaidya madam, MD OBGYN, fellowship and IVF and endoscopy. She was an ex-consultant, Global Hospital Baroda, ex-lecturer, MGM College, Aurangabad, now consultant at Anand Hospital and Bijampur IVF Center. Experience is of 13 years, faculty, MRCOG and local and state level conference. Please start now.
Sankhipriya, can you share my screen, please?
Yes, ma'am.
So very good evening to all of you and a warm welcome to everyone who's there. I'm starting primarily by thanking Shield and Dr. Sakre and all the 3 OBGY societies for having me here for this talk. Today's topic is actually, it's not a lecture or something. It's a short series of cases which I happen to handle in the last 2 to 2.5 years post-COVID. So I would like to give you a short introduction about how I actually stumbled upon these cases. To begin with, every one of us might have done an internal podiatric version sometime or the other when we were learning in our institutional phases. So like every catastrophe has some new development. The COVID catastrophe got this development with me. Usually now what we do is we either practice in obstetrics, as in we have an easy vaginal delivery or say a bit of a ruffle, but then we manage to have a vaginal strike, or else we opt for a cesarean section. But there are instances where even the vaginal is a problematic stuff and opting for a cesarean could be even worse than that. As in the patient has a lot of comorbidities or some other issues where, you know, you are not very comfortable doing a section either. So what there? So likewise, I was struck upon 2-3 instances where I had such patients and I could think of ECV as an option. And that is how I started doing. You can go back to the first slide, I'll just in a minute. When we look onto the external cephalic version in per se, we think of all the abnormal presentations we have, which are not more than 30% at 30 weeks. And once we wait till term, there are hardly 3 to 4% of them left. So currently what we do at the max, we don't opt for a difficult vaginal delivery simply because the scenario we work in, we don't want to take a chance with fetal jeopardy. But what if the patient has an abnormal presentation with a bad LRTI, maybe a comorbid heart condition or something in the brain? I had such patients where, you know, you are not even comfortable doing section and the patient is in her own jeopardy either wise. So there, I think I started thinking on ECV as an option. Also where we have an intrauterine demise, as Bapat ma'am said, it comes at different gestations and we really don't want a negative section. I mean, every obstetrician would like to avoid a negative section for whatever reason it could be. So their external cephalic version, I think, is of immense use, and taking it correctly would reduce the incidence of at least negative section, if not per se a difficult vaginal delivery. The funny thing is we don't try it because not much, we have not seen it, but it's really very simple. The incidence of succeeding in a version is more than 50%, which is almost a very good go if you pick patients correctly. So you can move to the next slide, please. So what is the role in modern obstetrics? As I said, we have a demise or we have a preterm labor where the fetal outcome is very poor. We are not sure whether the NICU is going to support like in a 26 or a 24 weeker, or say at, somewhere below 28 weeks where we are not very sure, or an abnormal lie together. So how do we begin with? We need to, next slide. What do we need at hand? We only need to screen patients correctly, as in which to include and which not to include. I think that's the most important thing. A gutsy obstetrician is actually not required. It's a gutsy patient and an opportunistic obstetrician. We need a good pre-procedural ultrasound to confirm that what we are going to attempt is absolutely safe for the fetus to take a somersault in the tummy. We need a good NST after that to satisfy the mother and the obstetrician both, and all the good inclusion criteria, and an OT backup ready for a cesarean section. I have attempted almost 10 to 12 versions till now out of maybe 35, and all of them, the rest of which I have negated and not attempted version at all because they simply did not fit the inclusion criteria. Next slide, please. Which ones are the inclusive criteria? The most important, an unscarred uterus, not even a previous surgery like as in a septal surgery or anything, everything I have excluded. A poor abdominal muscle tone is very, very essential for attempting a version, because we really won't be able to attempt a version at all if the body has a good tone, as in the compliance of the mother goes down, and we don't want vengeance while doing it. Appropriate fetal position, as in the type of the presentation which we have. A good fetal maturity, unless we have preterm in certain specific indications, as I told you, a demise or something, and an easy availability with a palatability of head of the fetus. I think these two are the most important criteria which I saw that would help us continue succeeding with version. Next slide, please. So which ones? You can move to the next slide. And I think she has an issue. Yeah. Multiparity is very easy because the abdominal tone is already lax. Transverse oblique are very easy to attempt version. Complete breech, another one. We need good amniotic fluid, unengaged presentations, and no signs of labor whatsoever. You'll be surprised to know that ideally, textbook-wise, we should attempt version at term, meaning 37 weeks and beyond. But the very first version I tried in a live baby was at 40 weeks. Simply because the other criteria were fitting, and God forbid if my teacher would know, she would have thrashed me if she knew I would have done at 40 weeks of gestation. So which ones do we not favor? Next, please. The excluding criteria, frankly, it doesn't have ballotability and it won't version at all. A tight abdominal tone, a decreased fetal head ballotability, meaning when they have a splinting action of the fetal part, even though if it is a partial footling presentation, it doesn't work. They don't move. Decreased amniotic fluid, cord round neck, even if you have the slightest of the doubt that there is a cord around even the shoulder or the neck or half through, unless you are very sure, don't attempt a version there. Anterior and lateral placentae are a big no for version, and any other obstetric absolute indication of cesarean where version is absolutely not going to help avoiding a cesarean section, we don't attempt a version there. And of course, any sign of labor. PROM is not a criteria for cephalic version. It could become a podalic version in that case. Next slide. So how do we begin with? We begin with confirming whether we are actually, you can change the slide size if you have. When do we do this? We do it till 37. Sometimes I waited till 38 weeks also, depending on if the fetal ultrasound is very good. We have ample amount of Liker. Then sometimes, watchful expectancy, there is spontaneous version by 38 weeks. We don't need to hurry and decide on taking an action for abnormal presentations at 37. Very rarely, 1 or 2 patients I've seen 38.5, approaching 39, they have version when there is huge amounts of liquor. But of course, there attempting a version is not a very good idea because it could revert again. And the whole exercise of attempting that would go waste. Unless you have a fetal demise, I think waiting effectively till term is a good idea so that it eases our attempt of going for a version also. We need to counsel the patient because the most important thing is the acceptance of the patient in case it reverses what to do. And in case we are not able to attempt a version or it does not succeed, then what next? That is the biggest worry that an obstetrician would have. So while attempting, I saw that once you are halfway through, if you're sure that you are not, very easy doing it, or you have some vengeance in your hand, or you need to put extra pressure, you can just straight away stop then and there. And you know that you need not attempt again. You can give one more shot, but I've never attempted more than 2. Wherever seeing that 1 or 2 attempts are not good enough to ballot the baby, then I've not attempted more. Unless it's an IUD, you can give an extra try. But believe me, it's not so much of force that is required. It's very easy, and the baby actually swims in the tummy if you pick the correct time. Next slide, please. So how do you go about it? I have not used any tocolysis for any patient. I haven't done it in the OT also. I have simply done it in the ultrasound room because I wanted an ultrasound and an NST machine handy. I only kept consent of the patient for cesarean ready in case I had an irredundancy, but God forbid, touch wood, I didn't have any as on. And a cesarean drum ready with an anesthetic standby. Not as in they were not standing with me around, but yes, I had explained to the patient. The patient lies in dorsal position with knees partially flexed because we also want comfort while moving the baby. So we keep an ultrasound machine standing so that wherever we feel that we have an issue or we want to hang up the procedure, we actually immediately can confirm what has gone wrong or whether what we have done is not actually jeopardizing the baby, and then we can continue attempting the procedure. Next slide. So there is the first thing is we need to, ideally I didn't attempt in any of the patients where the breech was engaged or even fixed, because dislodging the breech is a tough thing. It's already in the system and there are small Braxton Hicks already happening. So the breech, even if you dislodge, has a higher tendency to go back and sit in the pelvis again. So all unengaged presentations are very easy to attempt. And once you take a grip of both the, Saitya, you can explain the slide, please. Once you have both the poles in your hand, you can just try and put the baby in a forward somersault, as in the flexed head of the position. Once the baby is in transverse line, you can hold for a few seconds to let the baby have a kick or a go, and it makes the patient comfortable also, because once the baby is moving, she knows nothing is going wrong. And then you can change your hands and again try to reposition the baby in vertex. After this is done, check with an ultrasound, do an NST, ask the patient to walk along. She can walk in the corridor, go back to bed, and you can recheck the position and give another NST and make sure that the reactive NST and the quick movements are there, and you're done. So that's how easy was it. The anterior and lateral placenta I never attempted because they give a boggy feeling when you try to hold the fetus. So it's difficult, and we don't want anything to, anything unnecessary to happen while performing an elective procedure. So although it's not a complete contraindication as per the textbook, I think it should be safer to avoid patients with an anterior or a lateral placenta. Next slide. When to stop? As I told you, it's really the baby attempting to move because they naturally tended to go head down. So once you start moving the baby, they actually try to swim on their own inside the amniotic fluid. So if you feel that you're using too much of shoulder or hand pressure, or it's not ballotting very easily, you know that you are not choosing the correct patient, and we need to stop there only. Sometimes I have seen that when I have attempted, like I told you, in 40 weeks, or say the first patient when I tried, the patient had a huge LRTI. She was recently COVID negative, and she was coughing a lot, and she would have grade 3 risk if I would have taken on our table. So this was the first patient I tried to attempt virgin, and that is where I had to induce labor because I knew that she's anyways post-dated. So in such cases, once you get the line, you can start inducing labor then and there, because it's anyways going to take time for the patient to deliver. Of course, making sure that there is no cord again after your version is complete is where the ultrasound is required, and that's why I had chosen a room as my room to start doing the procedure. Next slide. This is a short case series that I have tried on 25 plus 5 transfers, and I attempted only 10. That means I sectioned out the rest of them because they were not in favorable positions for me to attempt. Out of these 10, I had 2 demises and the rest were all live babies. Saithya, can you post the video that I had given you?
Yes,
This
ma'am.
is
Just a second, ma'am. Yes, ma'am. Just a second.
the attempting version.
Dipti, I'm really impressed by your work. Have you posted this series somewhere?
No, actually, ma'am, what
Have
happened?
you shown this work of yours somewhere?
No, actually, I wanted to search for whether I have references. So I went on
Yes,
sites.
doing the way you are talking and the way you have done the work, I think it should be appreciated nationally. What you did. So please write properly and mail me.
Yeah, sure.
We will do in some other platform, we'll manage to do few things.
Okay, ma'am, sure.
Hardly 14 people are listening you. That's not the platform. I'll put you
Yeah.
somewhere else.
Surely, ma'am.
I'm so impressed. Yeah. Over to you.
Run it.
My God.
Yeah, no problem.
Just
Actually,
give me a
try
minute,
to.
ma'am. I'll.
Yeah. Should I try from my end if I have? I tried searching for references actually before putting it on a platform, but then I found out that people in America, there is a site of UK, NIH, and NCBI. They have a series of 100 patients. So then I was taken aback, Kavita ma'am, that we are not doing too much justice. And so I waited for more patients. It took me around 3 years to get to these many patients.
Shall I play, ma'am?
Yeah, sure. Go ahead. Okay, see, this is a breech presentation. The face of the patient has been avoided purposefully. I'm trying to take a grip of the cephalus and the breech now. And slowly I'll be dislodging and putting it into a transverse line. It's very, very slow and it's not at all a fast procedure, but believe me, it doesn't take more than 2 minutes. See, the baby is kicking, so I've stopped there. Sorry, this is an unedited video. I am actually changing my hands from the baby to get transverse and to change my hand to get it into a cephalus. Maybe the next patient there. I have changed my hand and now the head has come into pelvic grip and the left hand is moving the breech. The side of the back is from where I try to turn the baby. So it is like colanturi in the tummy of the mother.
Amazing, amazing, amazing. See, you are such a young person because I think senior people over there will agree with me while our house job and residency. We have done this, but in last 20 years probably this art has not been promoted. Am I right, Lalita madam?
Yes, madam. Yes.
Cephalic
Really, very amazing.
Now you continue. You finish it, then we'll discuss it.
the pelvis. So I confirmed ultrasound. And I have induced labor in this patient because she was 40 weeks. She had almost 13, 14 AFI, so it was a very easy job. See, the tone of the abdomen is very soft, so it is very easy for us. There's no vengeance, no force, nothing.
She doesn't look 40 weeks, but no? So
No.
the baby looks smaller.
It was a 2.6 kg. The first one I tried was 3 kg baby weight.
Okay.
Actually, I would like to thank Shiradkar ma'am. She is the one who started this KIDA.
Yes.
In MGM, I had this opportunity. I had an IPV to do in my call. around 6-7 years back. It was basically a 28-weeker fully dilated cord prolapse. So we thought of, that child is not going to survive. I would, and it was transverse lie with cord prolapse. So she said that, okay, anyways, take the patient in the OT and let's give it a shot. To my luck, I could attempt IPV, and I delivered it by a breach in the OT. After that, I forgot about all this. And then again, when I got the opportunity, I started getting a series, and then slowly I developed these many cases. So that's the end of my short presentation. Thank you so much.
Amazing, amazing. A lot good work you have done. Really appreciable. Everybody will appreciate it. You need a big platform. I'll see to it that you should talk in some big platform very soon. Very soon. I'll make it a point very soon. I am reaching out to unreached people. That's why I did this webinar today. I'm extremely sorry. And thank you, Vijay, with Anil, you have given me chance to speak here. But all three topics are very well important one, and we'll put it in some bigger platform soon whenever I get an opportunity. So thank you so much, everyone.
Thank you, ma'am, and very all the best to you for your.
Thank you so much, Beta. Thank you so much. Vijay, Anil has given some message to you, then that's why you are doing. Thank you so much for that.
No, ma'am. Thank you. And Vaidya madam, really thanks for this presentation, because since long time we are also carrying ECVs, and like as you said, maternal muscle tone is important, as well as uterine muscle tone is also important. Yes. So we have tried something giving the patient oral tocolysis, like start with the isoxsuprine 1 day prior, give a BID dose and call the next day. Okay. That gives a proper relaxation of the uterine musculature. One thing. Second thing is that what about the maternal muscle tone to be reduced? Because young patients having good muscle tone, multiparity is a good thing to be converted into an ECV. But like young patients, they are having more chances of having abnormal presentation, rather breach and other things. So like what you suggest about reducing some sort of muscle tone, reducing the muscle tone, like giving the position in a little bit flexed way.
Yes, flexing their knees helps a lot.
Yeah,
because their tones are really tight, and sometimes, most of the times I've seen where there are tight tones, the breaches are frank, they are not complete breach.
Yeah.
So breach is a big no-no. It doesn't help us anyways. It doesn't even go to transverse line. It comes back immediately.
And I think obstetricians always talk about the fingers. Doing an ECV is a magic of your fingers. Like one side, when you are working with your 4 fingers, and at the same time, on the opposite side, you are working with an thumb. So it is giving either clockwise or anti-clockwise movement. One thing. Second thing is that when the baby is a little bit, let's say bigger size baby or advanced gestational age babies, we can just lift up the baby little bit up and then start rotating. That gives them good advantage.
Okay.
Yeah. Thank you. Thanks a lot, ma'am.
Thank you so much.
Kavita, madam.
Unmute yourself. Ma'am, you are muted.
I'm going to speak in Hyderabad about the optimization of the cesarean section rates in this country. So the most important point, this is one of the things which we can teach our students, which we can teach our OBGYN, we can teach our paramedical staff to know about it. And actually one project is being done, how to breach the breach. Matlab BREECH to BREACH. There is a big process is coming. See, if we are able to deliver each and every breech delivery normally, so automatically the cesarean section rate will also go down. Am I right?
Right.
So, but this external cephalic version is one of the boon for the country like ours. I think I'll put it somewhere. And thank you so much, Dipti, for this topic. And who suggested this topic is really important. And the Vijay put a very good points along with it. Because see, a person you are young for all this, I think, for all this, which we have done. Nilima must have done ECVs long back. Am I right? Nilima, am I right? Nilima का ध्यान नहीं है.
मॅडम आता एक जस्ट सजेशन होतं की
बोला.
generally what we do is that, and obstetrician, बऱ्याच वेळा we keep an scan like an radiology part a little bit away from obstetricians.
Mhm.
What I feel is that it should be made mandatory for every obstetrician to go through a training of ultrasound.
Absolutely.
This ultrasound helps a lot in doing this ECV. Absolutely.
Vijay, I agree with you, but the problem, we are talking on this platform and it must be recording something. So